This is the advanced cardiac testing, and the first part of the advanced cardiac testing is to identify and measure the jugular venous pressure. And what you see here at the neck is the typical findings of the internal jugular, which is that it'll have 2 or 3 pulsations. You can see it here, but also down here. And what you want to do in your patient is to find the highest level of the neck where you can see the triple or sometimes double pulsation of the internal jugular. I say triple or double because sometimes you can't see all 3 pulsations of the internal jugular. The key to identifying this is distinguishing it from the carotid. The carotid is a single pulse, and internal jugular will be 2 or 3 pulsations per heartbeat. Now, once I've identified where the internal jugular is, I see it as high as right here on the neck. I'm going to measure and find out how much pressure there is above the right atrium. What I'll do is I'll take a tongue depressor, a tongue blade, start right across from where the highest level of the internal jugular is seen, and I want to take that distance right across to the sternal angle. And the sternal angle is this little ledge or bump that you feel across the sternum. The sternal angle is always going to be 5 centimeters above the right atrium. So if I know top of the internal jugular pulsation, and I know that sternal angle is 5 centimeters above the right atrium, I can then measure the distance from the sternal angle up to the internal jugular. And in this case, it looks like there's an extra 2 centimeters beyond that. So my internal jugular, my jugular venous pressure is then 7 centimeters above the right atrium. 2 centimeters above the sternal angle plus another 5 centimeters to make it a total of 7 centimeters above the right atrium. Now you notice that Eric is laying fairly flat on the bed here because he does not have an elevated jugular venous pressure. If I had a patient in whom I suspected heart failure, I would have to have that patient be sitting further upright in order to see the top of that pulsation. Now this is a technique you can practice in small groups in order to identify where is the top of that pulsation and then measure its distance above the right atrium. Next, I'll check for hepatojugular reflex. This is a test that's very helpful in a patient who has heart failure. Once you've identified the jugular venous pulsation and have determined the pressure, you can next look at that JVP and apply some pressure to the abdomen. What this does is presses some of the venous blood that's in the liver out of the liver, and you can see that pressure transmitted up into the internal jugular vein. In someone who has heart failure, when I press on the abdomen and move some of the blood out of the liver and the veins, that should very quickly cause the JVP to elevate. In a normal patient, as I press on the abdomen, I'll just see a slow, gradual, and difficult to see change in the internal jugular pulsation. So what I'll do is I'll press my hands on the abdomen and I'm going to press down, and you just keep breathing normally as I'm doing this, and I'll be watching your neck as I'm doing this. So I'll apply pressure and be watching where I see the internal jugular and watch to see if I see any elevation. And there is a mild and slow elevation in the internal jugular. Then I'll let my hand go again, and that will drop back down. The next specialized test that we'll check is listening at the apex and palpating at the apex while the patient is in the left lateral decubitus position. This is helpful if you're having difficulty hearing the heart sounds while the patient's lying on his back, or to accentuate those low-pitched heart sounds that are difficult to hear, and moving the patient to the left lateral decubitus moves the heart closer to the chest wall, and therefore you can hear the heart sounds a little bit better. So could I ask you to lie on your left side, roll over on your left side? And you can ask the patient to raise his left arm up over his head. Yep, just like that. And what I'll do is I'll reach around from the back and check over where the PMI is. Now, since the heart has moved a little more laterally, it's palpable here on the front of the chest a little bit more easily than it is while the patient is lying recumbent. So I've located that. I can note the intensity of it, and as I said, it'll be larger and more intense because the heart is closer to the chest wall there. Then I will listen at the apex Again, listening with the bell of the stethoscope is very helpful for listening to low-pitched heart sounds. So I'll listen with the bell over the apex there. Again, allowing several heartbeats to pass. And you can also listen with the diaphragm over this area as well. Now, in some cases, the patient is large enough, you may be small enough that you need to move over to the patient's left side in order to listen and to palpate in those areas. And that's perfectly acceptable to do so if you cannot reach across the patient's chest, such as what I've been doing here. Now, the last technique is to listen better to aortic valve sounds. What I want to do is move the heart closer to the chest wall so that I can hear the aortic valve and also the aorta as it's much closer. And the way to do that is I would have the patient lean forward and then take in a breath and exhale and hold his breath after he has exhaled. And this will move everything closer to the chest wall. So can you lean forward here and take in a breath and let it out? And then hold your breath. And that's good. And now you can breathe again. And you can sit up. And I'm listening over the location where you best hear the aortic valve, which, as you know, there's the sternal angle. Move to the right between the second and third rib, the second intercostal space, and this is where you best hear the aortic valve. Clearly, if there is an aortic valve disorder, you may hear it throughout the upper part of the chest, but this is the best place to locate it. All right, and that concludes the advanced cardiac testing.